Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Sandoz.
This program is presented by Medscape Education Global.
Hello, I'm Gavin Giovannoni, Professor of Neurology at the Blizzard Institute in the Faculty of Medicine and Dentistry, Queen Mary University of London in the United Kingdom. Welcome to this program entitled Paving the Way for Success in Integrating Biosimilars into Multiple Sclerosis Care, How to Optimize Management and Patient Communication. We have a unique and special program for you today, and joining me are Marlo Love, a patient and patient advocate based here in London, George Pepper, who I've known for several decades now, who is also a patient but represents Shift MS, which he found and is now the chief executive of, and he's also based in the United Kingdom. And we have Mavis Ayo, who's the MS lead nurse at the University Hospital in Southampton, and she works for the NHS. Why are we talking about biosimilars? So as you probably know, as innovation happens, patents expire on innovative compounds. So we have both generics for small molecules, and now that with biological therapies, which are protein-based therapies, when the patent expires, competition comes on the market and biosimilars emerge. And they are essentially driven by market forces. When the original patents expire, biosimilars are produced and get registered, and they actually bring down the price of healthcare. So we have a large number of generics in the small molecule space, but because biological therapies are relatively new, the biosimilars are quite a new phenomenon. And as you know, we treat multiple sclerosis with a lot of biological therapies, so we now be entering the phase where we're seeing more biosimilars emerging. And so we have to develop a strategy for effective communication between the healthcare professional and the clinician and the patient to ensure that they understand when they get switched from the innovative compound to the biosimilar. Now, the way we communicate this is really, really critical to ensure that patients continue to have the beneficial effects of their new treatment, to avoid relapses, and in the case of certain compounds, for example, rebound activity, and they continue to experience good safety and tolerability of the biosimilar. If we don't do this, we can often have the so-called nocebo effect, which is the opposite of the placebo effect. So the nocebo effect refers to negative symptoms or signs that emerge when you switch therapies or have a therapy. And this can lead to negative perceptions of the experience with the new therapy. So who better to give us some communication pointers than two people living with the disease, and also an MS nurse specialist who plays a fundamental role in our communication in our clinics. So the four of us will discuss all this in much more detail. We're going to use some clips with communication examples to highlight some of the key points. So can we get started? So Mavis, what is your experience with biosimilars in multiple sclerosis, and are your patients using them?
So we have some experience around biosimilars, in particular rituximab that we use off-label, and we have a great deal of experience around generics as well in our practice.
So when you had the rituximab biosimilar emerge, were there any issues that you had to address?
We haven't experienced any difficulties or any issues with the rituximab biosimilar.
Do patients often ask about what therapy they're taking? Or?
Not necessarily, no.
And we have a similar experience to you using rituximab biosimilars. And actually, I don't even think healthcare professionals now prescribe a specific form of rituximab. They just prescribe rituximab. So rituximab now is the lexicon. It's not the original innovative therapy. And I think this is highly relevant to MS because we're now moving into an era where we're getting a biosimilar available now for one of our biological therapies. We're moving from innovator natalizumab to biosimilar natalizumab. So if you had no experience with the natalizumab, the new anti-trafficking agent?
Not yet, not yet, but that will come.
So Marla, have you had any experience with the biosimilar?
I do. I am currently on a biosimilar, and I have been since the beginning of this year. I have seen no difference, although I didn't expect to see a difference. I think it was explained to me very well, and it was explained to me by people who I trust very much and have known for many, many years. So yes, I've been on it for several months.
And you have confidence in the biosimilar doing what the originator compound did?
I do.
So just to say to you that a biosimilar is not exactly the same as a generic, because a biosimilar is similar in the sense that because it's a protein and made in a process called molecular biology, every cell culture that makes these proteins is not identical. So the protein that comes out may be slightly different, but its effect should be identical. And there's quite a complex regulatory pathway for producing biosimilars to make sure that the quality is the same and they do what they're meant to be doing in terms of their effectiveness. So they are equivalent in terms of their biological effects to the originator compound, but not exactly the same because they're produced, it's basically a fermentation process. So sometimes there's more sugars or less sugars on them. So there are subtle differences between the two. So they can't be considered to be identical. So they're important for people to understand they're made as part from living organisms in a culture medium. Sometimes they're made by bacteria, sometimes they're made by mammalian cells, and sometimes they're made using chemical processes, but they are still the same product in terms of their effectiveness. So when they come out onto the market, they're the same strength, the dose, and they're meant to do exactly the same thing as the originator compound. So from our perspective as healthcare professionals, we rely on the manufacturing process to be ideal, and they go through a very, very strict manufacturing process, and the regulators have a very strict quality control to ensure that the biosimilar is very similar in the sense of how it's made and produced to the originator compound. Why are they important for healthcare systems? Because they're generally less expensive to the reference product. And they also have an abbreviated clinical trial program. They don't have to go through extensive phase 3 trials. They have to often have a head-to-head comparison to make sure they're doing the same thing. And so they're often cheaper to produce and to develop. But that's what's important about it. They reduce the cost to the healthcare system, and it's part of the innovation cycle. So George, your organization works with many people with multiple sclerosis. What are some of the emotional and social factors that may influence the acceptance or reaction to a new treatment, for example, a biosimilar, and the possibility of nocebo effects?
Sure. And I'd say firstly that the existing relationship that the patient has with their neurologist or their MS team more widely can have a profound effect on how well this information is received.
So this is one of the reasons why we need to use this discussion as an example of how best and to convey this information and how not to do it. So let's go through one of the scenarios. You are going to be taken off your current form of natalizumab and switched to a new biosimilar version. This will happen in the next few months. I can't tell you when, but it will be quite sudden. It's basically the same drug, but it's much cheaper for our healthcare system. When you are switched, we can deal with any questions you have when I next see you in outpatients. What do you think about that as a communication strategy?
Well, I'm immediately on edge because this treatment has been a crutch for me for many years, and so to be told that that's going to change is unsettling. Is the first thing I'd say. Secondly, just the choice of words like cheaper and basically are concerning. I think using them in the right way is really important. I think understanding, and this is a healthcare professional challenge, but understanding the patient that's sat in front of you and understanding if they're anxious, if they're analytical, really who that is and how they receive information is really important so you can deliver it in the most effective way.
Marla, how do you feel about how the information being pushed to the next appointment? Would you be comfortable with that?
I would be comfortable with it being pushed to the next appointment only if I've been given enough initially. Sometimes I think we're given information either too late or too soon. In fact, I think there's a happy medium. And what I mean by that is if you're given information like this months, let's say, before the next appointment when you might actually have the drug, I think it gives you too much time to start thinking negatively about it. So I think there needs to be some time before. For me, there wasn't, because I was actually given the information the day of my infusion that was the biosimilar. But again, because it was correct information, it was given in what I would consider a good way. I was not told it's basically, they explained it to me in a way that in my mind, I kind of thought about, headache tablets and how, there's generics of different drugs, etc. That was how I digested the information, and I felt comfortable to go ahead that day.
So to summarize, you think it's not only about the information, but it's the timing of the information.
It's important.
And possibly the detail in relation to the timing.
Exactly.
Okay. Mavis, how might this dialogue that we've just examined induce the nocebo effect?
I think it's also important to note who is delivering the information. So with Marlowe's experience, it was delivered by people she sees every month and that she trusts. And it's the confidence from the healthcare professional delivering it. So if we, as nurses, doctors, and pharmacists, are already negative about the biosimilars, that will translate to how we explain that to the people we look after.
I suppose also it depends on how big the centre is, because some centres, for example, have specialist MS infusion centres, for example, and everybody in that centre is trained around multiple sclerosis. In other centres, there's too few patients, they go to generic infusion centres, so the person doing the infusion is not necessarily an MS specialist, and they may be treating rheumatology, inflammatory bowel disease, and in that situation, I would expect the fact that they're not MS experts may also affect the interaction in terms of who's giving the information.
That is so true, but also at the same time, if they're in the infusion suite, that they're seeing other biosimilars being given and the patients are really well, that could also be a positive.
I have my own personal experience with the nocebo effect on a biosimilar switch. So we use off-label infliximab. It's an anti-TNF alpha therapy, and we use it for a condition called neurosarcoidosis. And when the biosimilar infliximab came out, we had no warning. People were just switched automatically from the innovator compound to the biosimilar. And a large number of our patients got adverse events. They complained of new side effects, injection site reactions to the biosimilar infliximab. And I think that's an example where this happens if you don't do the communication properly. And I know from a study that's been published that about a quarter of people who switched from the innovator infliximab to the biosimilar infliximab having to come off the therapy because of the nocebo effect. So this is actually not a trivial issue if it's not dealt with properly. Now let's take a look at another communication approach.
We know that you have had a good response to your current therapy. We want you to know that there is now a biosimilar of this treatment available. It's a new version of your current therapy, and it has been tested rigorously and approved by the national authorities. Many people with MS like you are switching to this biosimilar. It is a more affordable option that could help us give us more resources for other aspects of your care. I'd like to walk you through the information in these handouts that I have and answer any questions you have for me.
So George, how do you think of this example? Was it a good or bad, and why?
Yeah, I felt it was a really good example. I thought it was took the time to explain the process, gave information, the handouts, something they could reflect on following the appointment. So I think that would be seen as a good example. But again, it is important to understand who the patient is who's sitting in front of you, and if that's too technical, if they want more information, if they want to see more data. So I think on the whole, it was good.
Do you think bringing up the regulatory issues, the regulators approving it, do you think that's something important for people with the disease to know about?
I think yes is the short answer. and I think that some will actually really benefit from having that reassurance.
Marla, what's your impression of that?
I agree. I think people would benefit from knowing everything, including what I don't want to use the word cost. I think there's a very fine line in how you present that to a patient, because none of us want to feel like we're on something because it costs less. But at the same time, we're not silly, and we do understand that when you're in, especially when you're in a country where a mass amount of people need a particular drug, we do understand that the costs need to come down to make that easier for people to have access, etc. So I think it's important that we feel like we can be trusted with that information also, and that we're intelligent enough to receive that information. So I think it's a much better example of how we should be told.
And do you like the multimodal? Do you like having it verbally given to you and the handouts as well?
Yes, both.
And what about audiovisual? Maybe seeing it on a video, for example?
I think it would depend on the person, and to what George was saying about knowing who the patient is in front of you. I think for me, having the information given to me as well as the handout is enough.
Mavis, from a healthcare professional perspective, how is this better?
Marlo is absolutely right about the knowing your patient and the relationship between the healthcare professional and the patient themselves. Knowing them, and I normally would ask them, what have you read so far about this new version of the drug that's come out? And you can gauge their level of information that they have gathered themselves, and you can go from there. One thing you don't want to do is bombard them with all this information and they can't digest that information that you've just given them. So knowing your patients and establishing that relationship from the very beginning. It's important.
And what about what I would call misinformation or disinformation? So sometimes we get people going on to, these aggressive Facebook groups, or they get feeds from, various anti-science. I mean, how do you deal with that in clinical practice?
I think from the very beginning, when you first meet your patients in the newly diagnosed clinic, you direct them to Shift MS and the other charities, evidence-based information on websites. We are very fortunate that we have a number of charities, national charities in the UK that you can direct patients to.
And as a MS clinical nurse specialist in the UK, are there any resources that you as a group of nurses put together?
We have a few websites that we recommend to patients. We also have a UK organisation for MS nurses. We have, blogs from healthcare professionals and neurologists available for us as healthcare professionals and for patients to have a look as well. And I think we have the responsibility to look at the studies before we present them to patients.
Yeah, so I think there is a lot of signposting we can do to online resources from what I would call reputed resources, be it the MS Society, European Medicine Agency, the MHRA. This is how you have to counteract when they get the information from these certain sources. So I think the message, though, is you have to develop enhanced communication techniques which will improve how you communicate any switch in therapy, not just necessarily a biosimilar switch for people with the disease. So it's all about being open and discuss the data in a way that's understandable to people with the disease. We have an example from the infliximab biosimilar switch, where a study has been shown that there are like 4 tenets to good communications. So I think it's really important that all patients on the innovative compound who are going to switch are informed and what the goal of the transition is, and actually to get permission from them. Even though in some healthcare environments it's not possible to get permission, they have to have the switch because of central policy. But anyway, they need to understand that process. Give them reasons for the transition, maybe not use the word cost saving, but talk about how this will improve services because of the lower cost of the biosimilars. I think we also have to train the staff, and the staff need to give a consistent message. It's very unsettling if you get conflicting information from different staff members in the team. And I think we also need to train staff, particularly those doing the infusions or giving the treatment, about how to deal with the nocebo effect, what it means, what it is, and to try and reassure patients if they do develop any side effects or adverse events that could be due to the nocebo effect. So Mavis, I'd like you to summarize briefly what you think we've learned about from the generic treatments in MS and give us some practical tips.
So from our services point of view, it's important to communicate, and we would give out letters warning patients of the change to the generics and to the biosimilars, giving patients opportunity to ask questions either in clinic or face-to-face or telephone appointments. We give them links to reputable websites, as we already discussed. Reassurance and clear communication. I think the honesty is a really important component of that. And as you mentioned, training the infusion nurses themselves on how to talk to patients, because a confident healthcare professional will convey that confidence to the patients to negate the nocebo effect.
So it's all about education.
Education.
So I want to switch gears now, and I want to talk about JC virus testing. This is an issue unique to natalizumab, because natalizumab works by blocking trafficking of the immune system into the central nervous system. So if you do get a viral infection on the other side of the barrier, it can be quite devastating. And we see in a small number of people in natalizumab, they develop this condition called PML, progressive multifocal leukoencephalopathy, which is due to a viral infection of the central nervous system in people on natalizumab. So neurologists and nurses out there will know that we always screen for JC virus antibodies in people with MS because the fact that you've got the virus puts you at risk. If you don't have the virus, you're safe from that infection. And it's very important to communicate this risk in people who have MS who go on to natalizumab. So Marla, are you aware of your JC status? Is it something that concerns you?
Of course, of course I am aware, and of course it concerns me. Very fortunately, I am JC negative still after years of being on the drug.
I think it's important to stress, even if you became JC positive, it's still a minority, a tiny minority of people who will get the PML as a complication. And there are strategies we can do to de-risk that. So it's not a case of everybody who's JC positive has to be on another therapy. There are things we can do. We can increase the interval between dosing. We can do repeat MRI scans. So there are things we can do to de-risk it. As a background for healthcare professionals out there, we have to use a different assay for the innovative compound and for the biosimilar natalizumab, which has just come out. And these new assays do the same thing, but they are slightly different in terms of their sensitivity and specificity. And so results from the old assay don't necessarily come out exactly the same with the new assay. And that's just laboratory medicine. Two assays give you slightly different results, but the interpretation of the results, in my opinion, should be the same. So someone with multiple sclerosis who is tested positive when starting the biosimilar needs to be counseled around the risk of PML. So let's look at some examples of dialogues sharing the news with the patient.
One of the tests we do regularly, the JC virus test, now gives us a positive result, a low positive. This means you've been exposed to the virus and are now at risk for PML, which is a serious brain infection that causes severe disability and dementia and can be fatal. Both your past treatment and the new treatment you're on makes this worse, so we need to change you to a new therapy as soon as possible.
One of the tests we do regularly is the JC virus test. It has now come back as a positive, a weak positive. I don't want you to worry about it. We'll take care of it. As your nurse and doctor, we will look after you. So let's go to Marlo. Marlo, how would you like to hear this news?
Not with a sense of panic, for sure. I think it has to be, again, very balanced. I think in the first clip there was an awful lot of panic that I think would just send the patient into a downward spiral. It needs to be delivered in something, in a way where there is some reassurance. And again, it's the educational piece and being able to convey what is actually happening and what is the likelihood that this could actually develop into PML, but in a very calm way, and not with these kind of alarmist words.
And you'd also like handouts with this?
I think in this case, because it's something so serious, it has a different tone for me. I don't know if the handout for me personally would be necessary. I think I would just need the conversation, and then perhaps a link to further information. But the conversation would be the most important.
George, how do those scenarios make you feel?
Well, they were different from one another. I would say that language matters. The words, you know, the nuances, I think can have a real impression on people with MS. Again, particularly if they saw that treatment as being incredibly important to their to managing their disease. So that is important. But yeah, understanding, again, we're repeating messages, but understanding who's in front of you and adapting appropriately.
I mean, from my personal perspective, it takes more than a quick 1-2 minute conversation to communicate PML and the risk. It takes months. So it has to happen, I think, slowly, and you have to layer the information and increase the complexity of the information gradually. And keep coming back to it, because the retention of what you get told in clinic is very low, particularly around risk. So Mavis, you know, in your experience, you know, how common are these scenarios in practice?
Sadly, it does happen in clinical practice, especially I would say, the first one with too much information, and the second scenario as well, which brushed aside the magnitude of the conversation. And it's a known phenomenon around medical gaslighting. And I know you've written an article about this, where a patient's reality is sometimes just brushed aside and not talked about. And we are the healthcare professionals. You know, with the second clip, it says, don't worry about it. We will worry about it. And as a patient, I'm not quite sure if that is reassuring, I have to say, because once you say that, patients will naturally worry about it.
Maybe we can look at a third example, a third scenario. So let's look at the following clip. As you're aware, we do a test for the JC virus every 6 months. And if it comes back positive, this tells us if you've been exposed to the virus. This is important because if you're on natalizumab or the biosimilar, this puts you at risk of a very rare infection of the brain called PML, or progressive multifocal leukoencephalopathy. This is not related to the product you're on, but it's related to how the drug works. It blocks the trafficking of your immune system into the central nervous system, and it prevents the immune system from fighting the viral infection. With the new product, we have a different test. It gives us the same type of information, but the results may not be exactly the same, and your test has just come back as being weakly positive. Don't panic. Sometimes these tests come back as false positives, so I would like to check it to make sure it is positive. If it comes back as being positive, then it puts you at risk of developing PML in the future. It's not something that will happen next week. It takes many months to years for PML to develop, and there's no need to switch your therapy immediately. What we could do is potentially monitor your test every 6 months, and if the index is going up, then we could potentially discuss switching therapies, or we can monitor you with more frequent MRIs to try and pick up PML earlier. And if that's the case, we could stop the therapy. And if we diagnose the condition earlier, the prognosis is much better. I've got all these information leaflets for you to go away and read. And if you have any questions, please ask. Do you have any questions right now? Mavis, is that a better version?
Oh, definitely, especially towards the end. It's the invitation to the patient to ask questions. And the first 2 clips felt quite dismissive to patients. So I think the third clip was definitely better. The right information is there, and the plan as well, beyond the JCV testing. So it was way better.
Yeah, so in my experience, it's a continuous discussion, PML risk management. And I also got a little printout that I give them, and I can ring on where they are on the risk management on that. And I can keep that, and it gives them a link for more information online, and they have the option of coming back for more information or speaking to the nurse specialist for more information. And also our staff on our infusion unit are trained to reiterate the information every time people come up for infusion. They're probably not talking to you about it, Marlo, because you're JC negative.
Exactly. And that is a very good point, because we do have patients on the ward when I'm getting my infusion who are JC positive. So they do talk about it. We talk about it. It is important to know other patients and other people who have it and are living with it, and they are actually part of the plan that you were talking about in that third clip. And I think when you talked about having the plan read out to a person, or talked about at least, it gives you a real sense that you're being taken care of, and that's definitely the better way to say it to someone.
George, from a patient perspective, how do we as healthcare professionals get the balance right?
Well, I think taking the time, with that last example, it talked through, and took time and asked the person then asked to respond to their questions. But again, I think it's realising that people take on information different ways. I remember an infographic, I think you might have had a hand in, that explains to me very clearly what the risks were. And as I developed the JC virus, I could see how that changed my risk profile. So yeah, I think that's just recognising that some will be fine with a printout, some will want to respond to questions, and the way that people take on information is different.
So when the PML risk stratification came out, we actually found that, one of the companies produced this it was like about a 5-page information sheet from a legal perspective. People remembered nothing from it. And so that's one of the reasons why we developed that very simple one-pager, and now we got it online. So this is an example of where less is more, in the sense that simple communication often outdoes this long, detailed, 5-page document. So we realize that it's important to communicate risk in a very simple, understandable way.
And I'd just add to that, I would say that sometimes when it's a complex topic, using analogies can be helpful. So someone on shift.ms reported that their consultant had said that it's, in many ways, it's like spectacles. It's like getting your spectacles changed. The lenses remain the same, but the frames perhaps are different. And that's perhaps a good way of introducing the topic to people who are less technical.
That's very good. So Marlo, I've got opportunity here. If you want to communicate to healthcare professionals and their teams about this complex topic of switching from an innovative compound to what are you going to tell us as healthcare professionals?
I think I will steal from George and say definitely know the patient in front of you. I think that is paramount. I think deliver the information in a way that not only gives the information, but it gives a bit of a plan after. And I think to give the actual information in a conversational way, an educational way, not too much information, not too little information, not dismissive, and then to give some kind of a handout for you to research later.
From an MS nurse point of view, this is a relatively new thing for us, biosimilars. So it's important to educate ourselves so we're able to educate our patients. So that's my take-home message, education.
Well, I'm going to use the spectacle one. I like the spectacle one. Yeah. Same refraction, different glasses but different frames that are different. I mean, the other example would be, smartphone technology, There was the original that came out, and since then we've had a whole plethora of clones. And the advantage of the clones is they offer a cheaper price for people who can afford them. So this is what happens in healthcare. So maybe we should use that example as well. The software runs the same, but the cost differential helps people access that software at a cheaper price. So I hope we've convinced you that communication is critical to counter the nocebo effect that occurs when switching from an innovator to a biosimilar. And so I think if I can make 5 points, you need to reassure patients about the biosimilar's effectiveness and safety, and don't feel uncomfortable bringing up the regulatory process behind it. We have to trust our institutions, and our regulators across the world, make sure that when a biosimilar comes out, it's of a sufficient quality to treat people with the disease. I think you also have to improve your patient's understanding of the science behind biosimilars, what it means, including trial data, including immunogenicity data, including the manufacturing process and the regulatory process. And I think point 3 would have to be product specific, because the information will differ for example, an anti-TNF therapy and for natalizumab. And I think it's also very important that you have a process in place within your clinics to ensure patients understand biosimilars, and that what we're trying to do is not sell them a cheap product. We want a quality product, but what we're trying to do is improve the MS service in general, and part of the innovation cycle is biosimilars. And I think finally you should reinforce that biosimilars are quality product. They've been extensively studied, they've been through clinical trials, they've had regulatory scrutiny and approval, and they behave in a similar way to the reference product, and they should not be concerned that because they move into a biosimilar they're getting a less effective therapy. And I think that's the message we've got to get through. Final summing up points. Biosimilars are just like generic medications. They are a reality in our healthcare system. It's the way the innovation cycle works. And if you work in MS, you're going to have to get used to prescribing generics, and you have to get used to prescribing biosimilars. It helps release funding for other innovations in MS care. I think you have to develop systems and procedures so you can integrate them very smoothly into clinical practice and prevent long-term poor outcomes, particularly nocebo effect, where people want to stop taking this medication. And I think you have to be able to listen to patients and have a system in place for feedback. And for optimal communication, you need I would say a training program internally. And so not only are you, but your staff are trained to give a consistent message. And this has to be a moving target, because as new therapies come out, we're going to see new biosimilars emerge as well. And so although we think this is a new part of MS care, it's going to be the new norm. We're going to see increasing number of generics and biosimilars emerge, and we have to have a procedure and a training program in place to address the needs of people with multiple sclerosis. So I just want to thank George, Marlo, and Mavis for coming on. Your discussion was very timely, and I think this is a really important topic. And I would just like to thank you for participating in this activity. Please continue on to answer the questions that follow and to complete the evaluation.
This program was presented by Medscape Education Global.